Most PTs will treat TMJ pain. Almost none will ever treat or even learn about a full bilateral TMJ replacement paired with mandibular advancement and upper palate expansion. It's a lot of words. Today's guest stepped directly into that void. Our guest is a sports and ortho clinician, multi-university adjunct professor, and fellow in training at the Ohio State University. Her path to fellowship wasn't straight. It was a decade of clinical growth, unexpected mentorship, accidental specialization, and cross-country reset that opened a door into advanced OMPT training. But during her fellowship, her professional world collided with her personal life when a family member underwent this rare, complex surgery. Suddenly, they weren't just the clinician, they were the support system, the researcher, the problem solver, and the one building a rehab plan no textbook could offer. Today, she's bringing that lived clinical reasoning and that human experience and that emerging research to you. Say hello to clinician, educator, and researcher in progress, Katie Berry. Katie, welcome to the show.
Yeah, thanks for having me.
How'd I do? Did I do all right on the intro?
Yeah, pretty good.
I'm always nervous because we do pre-interview, obviously, because we want to get to the meat. Yeah. And I'm always like, I'd never like to show the intro to the guests because I want them to feel it at the same time that we're recording it, so it's real. But that's a lot going on. We're going to dive into that. But I want to start with what usually people do at the end, which is thanks for being bold enough to tell this, because this is not only work, but this is a little bit of personal involvement.
Yeah, and that ended up being a really wonderful piece of this. When I was thinking about the poster and obviously going through this whole process, when I reached out to other researchers or other folks who were working with TMJ, because it was something no one knew, by the time we got to completion, which was wonderfully a successful rehab, which I'll get into the dicey bits of that later, but that I had the perspective of being there at all aspects of it made it unique. And I think is what sort of set it apart as not just thinking about a new way to think about joint replacements or using an old way to think about joint replacements that we obviously know to a joint that's less known about, but also being able to integrate. You know, we talked to nutritionists and speech therapists and kind of got the whole thing on board because I was there every day. So that was a unique piece to it.
So I've got questions.
Yeah.
But my job really, and any good host, is to help you tell the story so the audience can understand it the best.
Sure.
So where does this story start? We could start clinically, we could start personally, but I want to start where you think the story should start. Where should this story start?
Yeah, I think my first real big exposure to TMJ was actually in residency. I did the orthopedic residency at Memorial Hermann. And one of my main mentors, Caitlin Lang, we ran across a grouping of TMJ patients. And to most clinicians, right, we hear TMJ and we're like, oh, that's somebody else is going to treat that, right?
Correct.
And I even ran into a couple of clinicians at AMPT when I was talking about this. And one who works in a TMJ clinic looked at this case and was like, oh, my boss would treat that patient, not me. And so I think that perspective of like, this is complex and it's different.
Yeah.
Caitlin was the first person who basically said the TMJ is just a joint. It is a joint like any other joint. It's a synovial joint. We are going to look at the mechanics, the biomechanics behind it, and we're just going to treat these people as they are. And there's been some really wonderful research over the last couple of years from a couple of different groups that have started to put out papers that really are, let's classify this, you know, myogenic, arthrogenic, is there a disc issue? And so I think my story started there at residency of someone just saying, hey, this is okay. We're just going to treat this and think about it with that clinical decision-making we would something else. Perfect. In the same way.
All right. So let's jump back to something I mentioned in your intro. Your journey to fellowship wasn't linear. You worked for years, taught residents and fellows, specialized in TMJ, as we mentioned, almost by accident. And we'll get to that. And then jumped back into advanced training. You went back to school after you graduated from school and also taught school. You were like, you know what I need? More school. But let's ask this. What part of that winding path, which by the way is always the best path, who needs a straight lines are boring, man. But what part of that winding path shaped you the most as a clinician? Or maybe I'll ask a better question, like what parts of that winding path do you look back on and say, yeah, that twist or that turn really shaped me?
Yeah, I think I get this a lot in discussions when I'm speaking with folks who are trying to decide about residencies or fellowships or other things, because my path is a little bit different. My entire residency cohort were just out of PT school. So they had all just graduated, whereas I had been out for 5 years treating as a clinician with the mindset of, personally for me, that I'm someone who needs to know a little bit more about how I'm interacting with something and what I know and where maybe I could grow more, and then seeking out something that will help me fill that. And so I think it sort of made that turn initially with residency, because I got to go into residency as a 5-year experienced clinician. And so we hear all the time, right? Residency is the equivalent of, 3 years of clinical work. You graduate and you're this expert clinician. Well, I got to go in as a 5-year resident and have conversations with my mentors in residency that were just like a little bit higher. I could apply my day-to-day as a clinician into that advanced learning. And so I think that's sort of where my sort of winding path changed a little bit into, I can utilize mentorship. I can be a mentor,
Mm-hmm.
share my experience. But as I was interacting with more researchers and more fellows in my day-to-day, seeing, okay, there's a little bit more, and there is already this wonderful established fellowship set of programs where maybe I can go, and it's the next best choice for me. If I want to get into teaching a little bit more, if I want to experience research at more of a one-on-one level, there's already a platform for that, which sort of is just the next best step, I guess.
Ooh.
Yeah.
I like that phrase. A wise person named Helena Esmond always said, when you're stuck, just make the next best step. And that simple reframe is really, it's simple, not always easy, but if you become myopic on purpose and say, my only decision right here is to make the next best step. Because I know from experience myself, I will think, but what about 13 steps from now? We're not at 13 steps from now. But I still need to be reminded of this, which is why Helena is great. She'll just say, what's the next best thing? So I think that's great that you end on that. So let's go to this. There's a game that we used to play at kids' birthday parties called Musical Chairs.
Okay.
And we always know we always go want when the kid or the adult is left out when they got no chair, right?
Yeah.
You sort of ran into that situation. You encountered bilateral TMJ replacement case during fellowship. Sorry. You became a TMJ specialist when your colleague retired. Is that right? And then suddenly you were left with no chair. You were the TMJ person.
Yeah. I was working at Kaiser in Northern California, and I had this wonderful coworker, Frank. And he was just a wizard with TMJ. And I was working out of an office, and he basically wanted to take a step back. He was in his path to retirement of sort of letting go of some of those specialties that he was doing and allowing other people to fill in. And I will be completely honest, I still don't consider myself at all a specialist in TMJ. But what it led me to was to say, again, that was an opportunity as a just out of residency clinician to gain a little bit more of a stepping stone in that medical system. And so I took it on and went and did the year-long course series of TMJ through University of St. Augustine, which was my first experience in continuing education that dove so deep, right? It was 3 full weekends of, like a very niche, very small.
Inch wide, but 10 miles deep.
Yes. Yeah. And completed those courses. The reason I also say not a specialist is I never actually took any of the final exams. I will own up to that one. I got the content and then
everything but the test.
Everything but the test, took it and left.
Love it.
Classic. And so got a chance then to help redesign and teach some of the TMJ classes that Kaiser Permanente was running, and then work with some of the other sort of TMJ specialists within Kaiser to just have some amount of a TMJ caseload. And for us, it still was pretty low. It was probably, 3 to 5 patients a week tops that we were seeing, but it was much more than I'd seen before any of that.
Yeah. What about stepping in that role taught you confidence, or did it give you confidence? I don't want to assume. And skill development, embracing uncertainty, like with what I get to do for a job, 1 minute I am confident, maybe overconfident, and then 10 minutes later I am wildly nervous about what is about to happen next. I'm assuming hopefully that I'm not alone, right? That happens a lot, even with someone with a lot of training.
Yeah. And I think anything new, right? We've got this like huge world that's available, and we know a little bit about something and decide, hey, I'll learn a little bit more. And I think what it does, or what it did for me in this instance, was it sort of brought up the floor, right? So TMJ is this wildly complex sort of umbrella diagnoses that has so many comorbidities and so many different mechanisms that are involved in it. And so it made the like very standard TMJ care easy. Okay, I can do all of this simple stuff well and correctly and get my patients on the right path. And so for a good chunk of TMJ patients, we know that sort of takes care of it. It's education and sort of some of the basics, and it can really create a better scenario for them. And then what it did was help me identify, okay, where do I put my more complex cases? How do I think about what might more be going on that isn't just those basics? And so it gave me that, to use our PT catchphrases, it gave me the toolbox to identify better what was going on with those more complex cases.
New business idea, by the way. I'm going to produce my own actual toolboxes. And then what you'll do is you'll prompt people to buy new grads a toolbox as a gift. And that'll be my only business model. I will sell the actual literal toolbox. Well, let's talk about the case that we alluded to in the intro. Sure. Where's this start? Is this who is, like, paint the picture for the audience? Let's do the W's. Who are they? What happened? How were you brought in? What'd you do next?
Yeah, this was also a little bit of a winding path. And I will say part of what made this case easier to write up, and obviously that's easier is still not alluding to the fact that I'm less than halfway done writing it up.
Simple, not easy.
Simple, not easy, yes. Was that it wasn't a typical TMJ case.
Which is what makes it so amazing and why people want to learn. You want to learn about the edges. The normal stuff we've sort of have in the bag. It's in the toolbox already.
Yeah, sort of. But most folks who encounter this TMJ replacement, it's juvenile rheumatoid arthritis or sort of a joint preservation procedure. So they've already been through the gamut and things aren't going well. And so they're going to replace the joint. And I think that's very typical to most joints in our body, right? We're not going to replace them until we've sort of run out of our conservative care.
And then I, on purpose, did no research about this. Well, not none, but a little bit. But I, on purpose, don't go too deep because I'm going to have an expert. So paint the picture of what this replacement, if a PT's like, hey, man, I'm doing more knees and hips and ankles. What's she talking about with the TMJ replacement? What's that look like in general? And what's that look like in this particular story?
Yeah. So in general, it's the same. And this is where I'll sort of use the comparison to most joint replacements, right? So whenever we're thinking about a knee or a hip or any of those things, what we're thinking about is the articular surfaces have broken down. And so you have a proximal and a distal end of that joint, and you're going to excise the proximal end and replace it with a component. And you're going to excise the distal component and you're going to replace it with an artificial component. And then they will articulate together as the new joint, right?
Well, yeah, when you say it, it sounds easy, but
but it's exactly the same thing. And so in that TMJ, right, you have an articular fossa and you have the mandibular condyle, and they articulate together. In the native joint, it's both a roll and a glide that happens within that joint. Once they install it, it's just a ramp. And so it simply they replace that condyle with a ramp, or the fossa with a ramp, and the condyle again, with kind of a mini condyle, but it simply articulates in one direction. It just glides. So
Okay.
it loses a little bit of the joint mechanics, and it becomes unidirectional. So the other complex piece to our native joint is, if we're looking at it head on, it also rotates so that we can you do lateral movement in our jaw, so we can go left and right, and that happens at the joint as well. In the new replacement joint, it just glides. All you get is an inferior glide. You don't get any more of that lateral movement, and so it restricts the motion slightly. It takes away those degrees of freedom a little bit, but you replace a joint that's broken down. And so you have this brand new surface that is able to move without those inhibitions that the native joint had.
All right. So now we understand sort of the A&P a little bit. Enough. Right?
A little bit. Yeah. I'm not sure if I did a great job explaining that.
Listen, you were doing roll and glide. Trust me. Yeah. You get 5 stars, no notes. If people are watching the video to this podcast, you can see some great articulation with But when you encountered this particular replacement,
yeah,
you found, am I right? Like, you kind of found almost nothing about what happens next. So we got to the replacement. We know how to do that. We just described in general, in big picture terms, what that replace, why we do it, what happens during it, what happens after it.
Yeah.
But then where's the playbook? I guess you found, what'd you find when you looked, and how do we bring this person back to function? Also, paint the picture for me briefly, what deficits look like when we're not rolling and gliding, we're just gliding. So paint the picture of what this person looks like afterwards. What'd you find? And if you didn't find anything, what'd you do about it?
Yeah. So when I went, obviously the first place to go, especially when you're a fellow in training, but also when you encounter something you don't know, is what have other people done? And so what I found was this kind of wealth of research on outcomes. So, these joint replacements have been happening, and they've been happening for years, enough that, Stryker, who's one of the companies that develops artificial joint replacements, they have a specific 3D printed patient specific joint that they'll 3D print for each patient, right? It's common enough that they've developed a system around it.
Sure.
And so I found research on outcomes, which is great for the surgeons, right? Because that is the question they have to answer is,
that's their stat, that's their KPI.
What are the outcomes?
Right.
And basically all of the outcomes were 6-month and 1-year follow-ups. And the outcomes are great. Improved quality of life, decreased pain, near normal range of motion and opening at a year, but nothing about how they got there.
The missing piece, the path.
Yeah. And even talking to the surgeon, which I was lucky enough because it was a family member to be at all of the pre-op and post-op appointments. He was first hesitant about PT in general because there's not a lot of PTs that see it and treat it, and didn't really know what was being done in PT. And so his only guidelines were, no force on the upper palate because it had been obviously broken and there was a surgical plate, and no lateral movement whatsoever because obviously the joint doesn't allow that. And so I found one case study that basically was like, PT is going to be so important. There's this thing called the Therabite, use it. I was like, okay. So I looked up the Therabite.
What is the Therabite?
It's like imagine like a car jack, but for your jaw. Like you crank it and it opens. And so the idea is that this patient is using, and it's used in TMJ treatment pretty frequently, actually, when there's an opening restriction. But that's the best sort of way I can describe it. And so it's got a lever and you put it in between your teeth and you crank it and it'll hold it open. And so you can get a passive stretch very easily on a daily basis. Frequency is important when we're working with joint motion. And so, but that was the only indication, was use the Therabite, work on range of motion, period, end of sentence. That was it. And so what it led us to do was, again, I had this 360 view, which was wonderful. And so we could talk to a nutritionist because until 12 weeks, the patient isn't allowed to have any solid foods, no pressure on the upper palate. And so we were working at a nutrition deficit. But then also to say, okay, if this was a knee total joint replacement, we have both healing timeframes that we go across. Are those remarkably different in the jaw than the knee or the hip or anything else. No, they're not, right? So we have our tissue healing timeframes. We have our sort of must-need early movement, right? We replaced a joint. We need to get that joint moving as quickly as we can. Does that still coincide with this joint? Yes, it does. Let's do that. And then beyond that, what are we preparing for? What are the milestones that we're trying to look for?
Yeah,
right?
yeah.
So
Where are the goalposts?
In a total joint replacement, right? First, it's let's get the quad active, let's get them off their assistive devices, let's get them walking normally, right? Then let's sort of expand on that. And so taking that same viewpoint for this patient, we were able to say, okay, right, our first is we need to get that early motion. How do we do that? With internal and external. And we chose to go with tongue depressors rather than a Therabite because we had them readily accessible in the clinic, and you stack one more on top and you can measure it. And
you don't use what you need, you use what you have.
It was easy and it was free. So we went with that. And then as we were progressing towards, okay, we need muscular endurance because at 12 weeks, the patient's going to need to be able to chew and tolerate that. So how do we load the joint in different directions to be able to start to simulate that? And then as our like really big umbrella, any patient that has TMJ complications, there's regional interdependence. And so we need to address posture and upper cervical spine and the neck and all of our postural muscles and how this patient is moving about their day and going about that. And so we were able to just sort of apply all of those same major concepts to this surgery and have a pretty good outcome.
It's the next best thing. I mean, everything that you just said, I don't know if you noticed it for the last like 2-3 minutes when you're describing that, you were talking about load, range of motion, and muscular endurance, where I think, myself included, when I heard TMJ, I would look around for who I was going to pass the hot potato to. But you're talking in terms that PTs use every single day and how we think. And one of the first things you said was, I believe it was your mentor said, this is a joint. It acts like any other joint.
Yeah.
But for some reason, and I can see it, why we might approach this or be hesitant to approach this, since there wasn't a clear, definitive CPG, it wasn't a path, right? You sort of built it while you were walking it. Were there any frameworks that you maybe stole bits from? Picasso said, good artists borrow, great artists steal. So were there things that you were sort of grabbing the best of, almost like a MacGyver?
Yeah. So in general, we took a couple of different, and I'll say Jake Bleacher, who is at Ohio State, was my main primary mentor working with the patient because they were also a family member. He was our primary treating PT, and I was present at sessions and doing the home
PT by proxy.
PT by proxy, yes. And doing the accessory sessions at home, which was nice to have. But
it's good to have a PT in the family, you know?
We always get, that's the Thanksgiving dinner topic. Oh,
correct.
Oh, my knee hurts.
My neck is feeling a little wonky.
You're like, that's great. Pass the gravy. We took a look at frameworks in general, right? Again, saying this is a joint. What is the CPG? I was at Ohio State at the time. So what are our Ohio State guidelines for total joint replacement? And looking at those components helped give us that initial framework of how do we want to approach this and what do we need? What are the guidelines that we'd normally be looking for and how can we apply that to this case? The secondary piece were the surgical restrictions. So we did have the restrictions of, listen to your surgeon. Always the surgeon is right with kind of what they're looking for. And so we had no pressure on the upper palate, which meant that all of our distraction had to be only with pressure on the lower jaw, which is typically how we treat TMJ anyway. The guidance of no lateral movement. And then we also had the restriction of no dry needling until 3 months. The surgeon wanted to be really clear of any infection. And so using those two things were sort of our bigger picture framework. But then we also dove into, there's a 2-article series that was done by, let's see, I have names. Stephen Schaefer, John Michael Brismay and Carol Courtney in 2014. And that was one of the first papers that really was like, let's break this down for the PT. How do we conservatively treat the TMJ? And then there's a million articles that go back with Roccabato and De Las Peñas, right? And sort of these more contemporary TMJ physical therapy really specialists and specialist researchers, and to say, if it was a conservative issue, how would we treat the muscles? How would we treat the joint restriction? And how would we treat the spine and the accessory to that? And so basically just combining, it is a post-op. How would we take those conservative measures and those post-op milestones and guidelines and meld them so that we can make sure that we are engaging everything that we need to give the best potential outcome.
All right. So if we're making a movie out of this, we understand the problem, where this started. And what was the initial injury? Did we skip that? What was the initial?
We did skip it. So again, this was a little bit avant-garde in sort of how we got here. Instead of an actual TMJ injury, this was actually an airway preservation procedure. So the family's got a history of sleep apnea and cardiovascular disease that comes with that. And so this family member was able to say, based on kind of sleep apnea testing and joint facial proportions, that they were already in a sleep apnea phase at a young age, and that would lead to
how old?
33.
Okay, yeah. So younger than I assumed when you were painting this picture. So that's a bad podcast host. I should have brought that up earlier. That's
right. Yeah. And so this is sort of where we ended up with a patient who had no TMJ complications to begin with, which led to, in my opinion, a much more clear-cut recovery because there wasn't that list of, I've already gone through all of this.
Sure.
Instead, what we got was from an airway that was 9 cubic centimeters of volume to 20 cubic centimeters of volume. So that was the intent for surgery, but the same surgery is done for those joint preservation procedures. And so the other benefit for this is we had kind of a clear-cut case, quotes there, certainly, right? And so in talking with other research or with other clinicians right now who have more complex cases, we have a little bit of groundwork that we were able to develop on something that wasn't complicated. And so that path now is, what are those complications with the more complex cases? And how do we make this a deeper, more extensive journey towards a CPG or something like that with those patients that have a more typical sort of presentation?
We need the moment then, Katie. If this is a movie and that's what a case report should be, it should be a snapshot. Everybody's on bated breath. How'd this turn out?
Great. So we were able to, again, the main improvement was that airway preservation. So a 2 and change fold increase in airway, but opening over 40 millimeters, no restriction in food, no pain, a return to full activity. So weightlifting, lots of aerobics. The patient can sleep on their back now, which
was impossible before.
Impossible before because they would stop breathing, and just full return. The biggest hurdle. So it was August of last year. So we're a year and a half out, a little over, has been salad.
Okay, why? I don't understand.
So you lose some of that lateral movement with the joint replacement.
Okay.
And so chomping salad straight up and down has been a little bit more of a difficult eating experience.
But who do you go to? You go to your speech pathologists, right? And say, hey, how do we fix this? Right? This is great interprofessional collaboration.
Yeah. So we had an incredible set of myofunctional exercises for tongue dexterity, for stretching the muscles as they were recovering.
I need some of these as a professional podcast host. I do need to increase my tongue dexterity.
Honestly, it was a lot of we think as PTs we have fun toys. I wanna spend a little bit more time with SLPs, like very fun toys that we
I call them cousins. PT, OT, speech, athletic trainers, chiropractors, right? We're all sort of in the same mess. I had a chance to work as a pediatric physical therapist in a clinic with that was more OTs than PTs. And I
Yeah.
sat back and they were behavior magicians. Like I was like, I have no idea what you just did. I watched it in plain sight. I saw the trick. I'm still baffled how you did it. So this is a great example of bringing in our SLP friends that could make some amazing results together.
Yeah, it was really neat. There was a lot of, we had our one complication that we had was sort of a middle ground.
Okay.
We were getting really great range improvement. It was kind of just before in that sort of 8 to 12 weeks. But one of the typical complications, which was written up in all of the results papers as well, that seems to resolve is a facial palsy. Because when you go to replace the joint, you're going right next to the facial nerve that's right in front of that temporomandibular joint. And so there was some facial droop, which meant if you can only have liquid foods or soft foods and you're slurping and it's coming out of that side of your mouth, right, you're losing your nutrition.
Yeah.
And so that was really
and you're uncomfortable and it's annoying and all those
you're drooling.
Things. Yeah, it's
no
so
one wants
stinks.
to drool.
Right.
And so, yeah, a really wonderful set of exercises to help sort of regain that facial tone to be able to control those muscles in a way that was really incredible. So,
all right. Well, now we need a question for you. You were both clinician and family member. Of course, you kept your professional objectivity, but you're still invested. How'd that dual role change the way you thought about pain, healing, communication, drooling, the emotional side of this recovery?
Tell you what, living with someone who is having trouble getting enough nutrition, like hangry to a new level. And I say that with great love in my heart, but that was a component, I've thought about that nutritional component before when we're talking
I don't
about
think I would have. Yeah, I don't.
Recoveries, but it really was, it made a difference, right? Pain was worse. Compliance with exercises was worse. All of this sort of wove around this continual, just like hunger, right? Like this patient was always hungry. And I don't think that I would have put those things together. I think we did the pain neuroscience education, which is important with any of this. We did the frequency education. We did all of the normal kind of PT line of things, but seeing it from that other side and recognizing it was coming from a different place was also, I don't think I would have asked those questions in the same way.
It's not on a chart.
Asking those extra layer of questions of like, how is it going for you? And we sometimes ask that, but maybe not as open-ended. And so with something like that, right? Like, how are you actually feeling? Like, yes, you've got a little pain. Great. Let's talk about that. Yes, like things are coming along, but like, what are your biggest struggles right now? And for this patient, it was, I'm hungry and that's making everything miserable. Yeah.
And this is going to sound like a crazy aside, but maybe for some of the audience who knows, I was a radio broadcaster and I was actually interviewing someone, a rock star, who had some substance abuse issues. Yeah. And it wasn't the first question I asked. It was probably 6 or 7 in, but I asked, how are you doing? And I left it super open-ended.
Yeah.
But this was public. This is very, very public knowledge. And the entire tone of the conversation changed. And we got to something that I opened the door for the musician who wanted, he didn't have to walk through. He could have said, I'm doing great.
Right.
We went down that road. I think I warmed him up enough to do that, but that's not in your EMR.
Yeah.
That's not a thing to ask. But I think the reason we're telling both these stories is it's a thing to ask.
Yeah.
And you'll get some great information.
That was we had already sort of consulted in the nutritionist, but it took a whole different tone of
totally different tone.
Great. How can we, you're having to drink all day basically to get enough nutrition. How can we supplement that? And some of it was protein powder, but some of it was, there are really nutrient-rich foods that you can blend pretty easily. And the patient was like, we weren't going to blend pizza or anything like that, but Indian food ended up being one of the main things because lots of chickpeas, lots of paneer, lots of tofu, Thai food as well. And those were things that the patient felt comfortable blending up, but all of a sudden had a wealth more nutrition than a fruit smoothie with protein powder in it.
I did not have Thai food on my bingo card of things that we would talk about in this episode, but it makes logical sense.
Yeah. Yeah.
So 2 more questions for Katie.
Sure.
What's one mindset shift clinicians need when facing a condition like TMJ replacement or just something where the research really is thin and the playbook doesn't exist yet? What would you say to them?
I think where I went and the advice that I got and the advice that I've gotten from many mentors in the past is identify sort of your primary issue, right? Like, what is it that you're treating?
What are we trying to
How did
solve?
you get here, right? Get your baseline of what it is. Look for what does exist, right? Researchers have come before us and they've done a wonderful job to outline those things. Especially when it's sparse, a case report or, not necessarily looking, it doesn't have to be a systematic review always. I got a chance to work with Todd Davenport, writing up some case studies in the Kaiser residency, and his perspective was, every case can be a case study. It's the viewpoint of what you did and how you did it that's impactful. And so when there's a sparsity of research, sometimes those case studies can give you at least a leg up of how someone thought about an idea. But beyond that, using the things that we already know. We are musculoskeletal experts, right? On graduation, and only increasingly so as we have career and hopefully advanced mentorship. A big plug for that. But using the things that we know and breaking things down to the simplest blocks, and then making sure that we're engaging our patient in those things so that we have our sort of research-centric, our clinical decision-making hat, and then our patient, and putting those things together to have the best outcome for the patient, right? Which may not always be our best outcome, but combining those things in that way.
All right, so that was a sort of an wide open question. The last question we'll ask here, we'll make it very specific to this episode in this case.
Sure.
What's one thing you hope every clinician does differently the next time a TMJ patient walks into their clinic? What's a thing that you hope every clinician hearing this does?
Yeah. I guess a couple fold. First, I hope they take that patient, right? Don't pass it off. Take the patient and give a baseline, at least in our own clinical experience of having treated that patient or being the point on that patient, right? The second would be involve other clinicians. The reason we love working in clinics with other people, right? Or at least I do, is that there are other people there who have seen things and treated things differently, or that approach problems in different ways. And so using the knowledge of others is absolutely one of the strengths of our professions.
Yeah.
And then the third would be to say, there are these great breakdowns. There's a couple of those articles from 2014 in JOSPT and JMMT that go through and start the breakdown of here is, what muscle, what joint, and what disc looks like in those patients. And here's how we can at least baseline treat them. Those things exist. I don't think we see them as often as we see ACL and the rest of that in the literature, but they are there as at least your initial blueprint, print it out, read it right before you see that patient, and then come in with a little bit of a toolbox and then an area to grow.
Perfect. Katie, before we started recording, we said we made this a conversation. We hope it was useful. The audience decides if it was useful. How did we do on conversation, though?
I think pretty good. I've definitely enjoyed sort of nerding out a little bit on this. Obviously, it's something I dove into, so I appreciate the open-ended and direct questions.
Good. Well, that's the idea. Is PT's super narrow, and then there's all these little nerddoms that exist in those. And I think now in 2025, 2026, I don't think nerd is the term. I don't think it has the sting of what it used to. Now it's like people embrace the nerddom. And I think especially in our profession, we all benefit from that. And when you can get these like-minded or opposite-minded people together and learn from each other, an episode like this might not make sense for someone who typically only sees knees and hips, except it does in case, or the mindset shift of the things that Katie did or learned. You had a lot of different things that aren't necessarily standard in this particular situation. So on behalf of AMS, thanks for sharing.
Yeah, thanks for having me. I'm glad to, again, the hope with this really is just to start a conversation, because these surgeries are out there. People are treating them. I'm working with a few clinicians right now, and it's the first real wonderful discourse that I've been able to have in a way like this. So hopefully it just builds so that when it does come across you or me again, that there's something, that conversation has been started, and we can go from there.
And if people feel stuck, what they'll do is they'll go, I heard this on a podcast. Let me find that episode. I'll send it to you. And now Katie's the resource.
Yeah.
Katie, thanks for your time. We appreciate it. Thanks for coming on this podcast.
Yeah, I appreciate it. Thanks so much.